Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, September 26th, 2018, for our Medical and Surgical Oncology lecture. Just a few preliminaries and then we'll go ahead and meet our guest and get started with the presentation. If you need to reach us for any reason because there are any technical issues or any last-minute questions, please go ahead and call us 919-445-1000. You can also go ahead and reach us via email at unccn@unc.edu. We'll be using Poll Everywhere today. We're on the web at unccn.org. You can find us on Facebook, Twitter, Instagram, YouTube, lots of places throughout social media to find out more about us. All right, we'll be using Poll Everywhere today. Dr. Khagi has several questions for you towards the end of the presentation, one at the beginning, and then an opportunity for you to ask questions at the very end of this presentation. A couple of ways you can join Poll Everywhere. One is to go on any web browser, including a smartphone web browser, to Pollev, that's POLLEV.com/UNCCN. So you go to that URL. As we raise new questions, you'll see them on your web browser and you can respond to them there. We also have many people who use their text-enabled phones to go ahead and join us. And so if you have a phone that has texting capabilities, in the to field you can type 22333, and in the message field type the letters UNCCN. You do that one time, you'll get a response back that says that you're joined for this session, and then for the rest of the afternoon, you'll be able to respond to questions as they show up on the screen here. So whichever way you prefer, but we hope that you will be joining us in an interactive fashion through Poll Everywhere for this presentation. All right, just so that you have an idea of what our first polling question will be, glioblastoma is an aggressive type of cancer that can occur in the, and you're going to pick A, B, C, or D, A, liver, B, lungs, C, brain or spinal cord, or D, kidneys. We'll come back to that question, but if you want to respond to that now, you may. Our guest today is Dr. Simon Khagi. Dr. Khagi, welcome. Great to have you here today.
Thank you for having me.
Well, let's see. We've got a little bit of information about you. Let's see if we've got it right. MD at the UNC Lineberger Comprehensive Cancer Center, and a member. You're a member there, an assistant professor for the Department of Neurosurgery at UNC Chapel Hill.
That's correct. Yes.
All right. As director of the UNC Brain Tumor Program, Dr. Khagi works in close collaboration with a wide range of supportive specialties to provide patients with a truly multidisciplinary approach to the treatment of central nervous system malignancies. Your research efforts center around improving treatments for patients with aggressive brain tumors, i.e. glioblastomas, and metastatic disease to the brain from lung cancer.
Yes, that's correct.
All right, good. What's one thing we left off, something we should know about you that's not on there?
I try to tend to be a very normal person. I have an golden doodle that I adore, about a year and a couple months old.
Great.
Keeps my wife and I pretty busy.
Terrific.
We really enjoy living here in North Carolina.
Great, great. Are you a North Carolina native?
No, I grew up in St. Louis, Missouri, actually.
Oh, very good.
Yeah.
All right. Well, glad to have you here today. We've got a few disclosures to get out of the way. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. Thomas Shea consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. Dr. James Coggill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. The speaker, Dr. Simon Khagi, MD, consults for Novocure, but is not compensated for that consultation.
Yes, that's correct.
All right. Let's see how they did with that poll. I see a definite trend here.
Experts.
All right, good deal. So we're right on target there with brain or spinal cord. And without further ado, tumor treating fields for glioblastoma. Dr. Khagi, let me pass the controls over to you.
Thanks, Tim. All right, so thank you everybody for joining us this afternoon for this presentation on tumor treating fields for glioblastoma. As Tim mentioned, my name is Dr. Simon Khagi. I'm an assistant professor in the School of Medicine, Department of Medicine, Division of Hem-Onc, as well as a secondary appointment in neurosurgery. And I currently direct the UNC brain tumor program and have been doing so since 2016 when I got here. So one of my interests, of course, is to improve the management of brain tumor care here at UNC, and in doing so, I also try to empathize and really try to stand in solidarity with my patients. So, in kind of a crazy idea that I had, I decided to shave my head, and this is what I used to look like here on screen, very professional. And basically, in order to raise money, to raise awareness for this disease, during this 5K that we have yearly, I decided to, again, like I said, shave my head, but it would be done so by the team that raised the most amount of money. We had a team that raised almost $25,000, and that I felt was probably enough to let them shave my head. So they picked a reputable barbershop, got me in a chair, shaved my head. I had a little bit of media coverage at this event, and it really made for a truly memorable experience. This is the team that raised the most amount of money. Furthermore, I actually put on the Optune device. I see a lot of my patients wearing it. I make these recommendations almost every day, but I have absolutely no idea what they're going through. So I, in addition to removing my hair, I had a patient of mine. You can see here, actually applying the device here with her backpack to my head, and I had, you can barely see it here, but I had the backpack on, and I did run this 5K that day as well. So it was a truly amazing experience overall. So in addition to seeing patients here, part of my job is to educate them, their families, as well as the people I work with on glioblastoma. And during this lecture, there's going to be a few key takeaways that I'd like everyone to understand, as well as some learning objectives that we'll have a few questions about later on in the talk. But glioma management, which is sort of the umbrella term which glioblastoma falls under, is a very extensive field. It's comprised of many diseases, besides the most common ones that we may all know, such as GBM, diffuse astros, oligodendrogliomas, but there's a smattering of other types which we won't get into. But GBM, of all of those, remains the most difficult to treat. The Stupp Protocol, which really came about in 2005, is sort of one-size-fits-all model for the treatment of these high-grade gliomas, is certainly being challenged, and rightly so. We have here the recent approval of Tumor Treating Fields, otherwise known as Optune, for the treatment of glioblastoma in addition to standard of care chemotherapy, and that's certainly a takeaway I think we should all take back with us after this lecture. It is now a Category 1 NCCN recommendation. And that being said, it should be considered a standard of care in newly diagnosed glioblastoma. Some of the learning objectives, we're going to discuss the outcomes and treatment strategies for GBM prior to TTField introduction. We're also going to talk about the mechanisms and the research surrounding TTFs and what led to its approval. And we'll also describe sort of the evolving role of TTFs in the setting of GBM, both for newly diagnosed and recurrent disease. So just a broad overview, what is neuro-oncology, sort of what do I do? I'm actually a medical oncologist with neuro-oncology training, and within sort of my specialty, a lot of my focus is really on the primary CNS tumors and metastatic disease. My neurology-trained colleagues who go through neuro-oncology fellowship also may focus on perineoplastic syndromes related to cancer, neurologic complications of cancer therapy, but being an oncologist, I stick to the cancer aspect of it all. And sort of moving down the line here, you can see here that our talk is really going to be focusing on the high-grade gliomas. Really quick epidemiology here, but between 2010 and 2014, we've had about 370,000 primary brain tumors diagnosed in the United States. Sounds like a pretty big number, but within a single year, you may have 250,000 breast cancer patients diagnosed per year. So it is still a smaller, less frequent cancer, which is probably a good thing, and of which 30%, about 31%, are malignant within that time span between 2010 and 2014, and even a smaller proportion of that are these malignant gliomas and glioblastoma. Unfortunately, glioblastoma is actually the most frequent type of malignant brain tumor in this category. And as far as the incidence, geographically, sort of above the Mason-Dixon line, you have a little bit higher incidence of this disease than below. Some of this might be related to the fact that there are slightly more minority populations in the South from Hispanic origins, African Americans, which do tend to get less primary brain tumors. And here we have sort of the incidence between males and females. This is has a higher predominance in males, GBM specifically, but more broadly, almost all gliomas. And between Caucasians and African Americans, this has a higher predominance, almost a 2-to-1 predominance in Caucasians. The exceptions are meningiomas and tumors of the pituitary. There's a slightly higher incidence in African Americans. By age group, we see here that the incidence does go up with age, significantly more so in the meningiomas, which is the more non-malignant type of brain tumor. But the GBMs also have this tendency to increase with age and kind of level out after age 65. The incidence sort of over time, which I find very interesting, is that it has been pretty flat. It has not increased within either all gliomas or specifically GBM between 2000 and 2014, which maybe some of your patients may ask, do cell phones cause these tumors? I think, broadly speaking, the answer is probably not, based on the incidence here, because we should have seen a spike probably around 2006, 2007 when the the iPhone came out and the higher prevalence of cell phones in the country. So it's probably not related in this case. So a little histopathology. We have here the origins of gliomas. Specifically, if we want to discuss GBM, we talk about astrocytes, which are basically cells that make up the architectural components of the brain. They don't necessarily send and store information, but mainly surveil and maintain the scaffold of the brain. You have the grade 1s, pilocytic, primarily in children, the grade 2s, diffuse astro, which is going to be primarily in somewhat of a younger population, the grade 3s, which you see a transformation from grade 2 and grade 3, is somewhat of a continuum, and that eventually ends in a grade 4 glioblastoma. The ones that go from a grade 2 or a grade 3 and turn into a GBM, we call those secondary glioblastomas, or transformed glioblastomas. Patients that develop a glioblastoma sort of out of nowhere without a predisposing lower grade tumor, we call those primary or de novo glioblastomas. So the characteristic appearance, and the reason why it's in quotations is because there isn't a characteristic appearance of a glioblastoma. This is, what the textbook might show you, a very nice, diffuse, heterogeneously enhancing, essentially necrotic, cystic-looking butterfly lesion. However, these tumors can be anywhere within the brain, within the cortex, deeper within the brain, involving the thalamus and even brainstem, and traveling down the spinal cord. They can even be non-enhancing. About 30% of high-grade gliomas do not necessarily have to enhance on MRI. That's why it's so important to get a biopsy or even a full resection if you can. And sort of the histopathology here, you can see more or less a classic pseudopalisating necrosis, cellular atypia, and a proliferation which is quite high, and microvascular architecture suggesting a very aggressive lesion under the microscope. So some of the molecular markers are also very important to consider when treating glioblastoma. In this case, MGMT has been very well known to portend a predictive value to response to alkylating agents such as temozolomide. You can see here in the companion paper to Stupp by Khagi, published at the same time, you have patients that are MGMT methylated clearly surviving much longer than MGMT unmethylated patients. And when they looked at patients who had radiation combined with chemotherapy versus those that had radiation alone, the methylated group did do a lot better in the combination therapy arm. You can see here with this line here. But really, all of the methylated groups did better than the unmethylated groups. That is not to say that we should not use temozolomide in the setting of unmethylated patients. They still do derive a synergistic benefit of radiation and chemotherapy. Sort of the background, the mechanism behind the MGMT and why we talk about it. MGMT, actually what we're looking for in terms of the methylation status is actually whether the promoter for the gene product is methylated or not. It's not necessarily the gene itself as the promoter of that gene. So if it is epigenetically silenced, you have downregulation of this DNA repair mechanism, which in this case would repair this methyl group here that's being formed from alkylating agents back to its normal oxygen here on that guanine residue of DNA. We essentially develop these ways of fixing our DNA because of intrinsic exposure to carcinogens such as UV radiation, and MGMT certainly isn't the only DNA repair mechanism. ATR, ATM, PARP are all sort of part of that process of repairing DNA. Another really important biomarker, molecular marker rather, in gliomas is the IDH mutation. It is now mandated by the WHO in its 2016 edition that IDH needs to be a part of your diagnosis for glioblastomas, or really any particular type of brain tumor, because it really is a truncal mutation that defines lower grades and are absent in the primary GBMs, or rather de novo GBMs. However, if you do see GBMs that have an IDH mutation, you can be very certain that even if the patient did not have an antecedent low grade, it most likely evolved from that low grade. So GBM with IDH mutations are likely transformed GBMs from low-grade tumors. And what is IDH and how it plays a role? Really quickly, going over this, you may remember the Krebs cycle, which we all loved in medical school. But basically, normal IDH takes isocitrate from citrate and converts it to alpha-ketoglutarate. However, a mutated IDH1 or an IDH2 protein further takes that alpha-ketoglutarate and converts it to 2-hydroxyglutarate, which acts as a kind of a global oncometabolite, which in turn is hypermethylating and silences a lot of genes, tumor suppressor genes as well as oncogenes. So more or less you have a low-grade tumor that is slow-growing, and I wouldn't say necessarily indolent, but it's much slower growing than an IDH wild-type tumor that doesn't have this oncometabolite 2-HD to kind of tamper down the entire process, and will likely grow a lot faster and more aggressively. So it is very important prognostically, not so much as predictively at this point, in the diagnosis of GBM. And here we see that IDH mutated tumors have a much longer survival than those that are wild type, both in the grade 3 anaplastics and the glioblastoma. So why is GBM so difficult to treat? Well, the trouble with it is that it has, in addition to the molecular markers that I mentioned, it has a lot of intra and inter-tumor heterogeneity. We found that back in the late 2000s that there might be these subtypes, or based on the TCGA atlas, that basically have their own genomic signatures as well as a predisposition for survival characteristics, showing that you see the pro-neural subtype having a longer course than the classical and the mesenchymal subtypes. So this is something that we've been occasionally thinking about, and most recently it's actually been challenged about how necessarily this all plays into prognosis. I don't personally get these subtypes on my patients. I think this is still kind of in the realm of research, but it is being talked about. And this is just a heat map and kind of a schematic of how these subtypes evolve, basically gaining mutations one step of the way, and then eventually differentiating based on certain genomic signatures. As you can see here, based on this heat map, you can see a proneural subtype having more of these types of signatures here than, say, for example, the mesenchymal subtype. It's just a very different type of signature pattern. What's interesting and how we're using this information is now that we're actually looking at the evolutionary aspects of GBM within the actual mass of the tumor. Here, and I'm not going to go too deep into this, but you can see here what PN stands for is the perinuclear zone, CL stands for more the central zone, or sorry, CT, sorry, it's more the central zone, and then the PNZ is the perinecrotic zone. Each of these zones seems to have its own molecular signature that corresponds to the proneural subtypes, the neural subtypes, the classical subtypes, and the mesenchymal subtypes. So you actually have these 4 subtypes within a single tumor that tend to evolve based on the stressors that we put on it, which is incredibly fascinating and was described by Pradu just most recently in an article in Neuro-Oncology. It's a very elegant paper if you have time to read it, but basically it describes sort of this intratumoral evolution based on the location of each cell and how each cell can actually switch to a different molecular subtype based on sort of the evolutionary stressors. So this is sort of the disease that we're dealing with. This is the animal that we, that constantly changes in order to acclimate to its environment. And from an immuno-oncology standpoint, checkpoint inhibition in particular has not really worked out very well because the neoepitope, sort of neoantigen load or tumor mutation load, whatever definition you want to use, has not really shown that it hasn't been that high in glioblastoma because, again, it's not a carcinogen-driven malignancy unlike melanoma with UV radiation and lung squamous and lung adeno with cigarette smoking. So you have a very, very sort of immunologically cold landscape in glioblastoma. So the checkpoint inhibitors have been resoundingly unimpressive, unfortunately, at this point. Now, combining them with a virus or CAR T cells or something else down the road may hold more promise. So first things first, as far as treatment goes, we have surgery. So we do the best we can. Of course, a gross total resection, getting out 90 or above percent of enhancing disease is going to improve your survival in these patients, but we know that we can't get everything out because of how diffuse these malignancies can be. 5-ALA was just recently approved by the FDA to sort of color the tumor so we can see it better under fluoroscopic light. At a particular wavelength. I'm not going to get too much into detail, but basically 5-ALA is a byproduct of the porphyrin pathway in heme synthesis. So the tumor takes it up, and under a certain light, you're actually able to see the tumor a lot better and have a more extensive resection. You can see that the progression-free survival based on the completeness of surgery does increase over time, so it's great that we can increase our progression-free survival. However, overall survival doesn't seem to be affected all that much, again, because it's not a surgical disease. This is a disease where we do need systemic therapy following resection. The Stupp protocols you may be all familiar with. We have radiation combined with temozolomide, and that did show a survival advantage, however pretty insignificant compared to other cancers. I mean, we were ecstatic that we got 2.5 months from this regimen. It is something that has been in place since 2005. So that brings us to what's been going on most recently and why we're excited about alternating electric tumor treating fields, otherwise known as Optune. This is an example of actually an actor wearing the device on their scalp. The scalp needs to be shaved. These things are called arrays. These little ceramic discs have electrical leads that come off of them and plug into a battery pack. These are mobile, portable batteries that can be recharged at home. And patients have to wear this at least 18 hours a day. So why are we talking about this for the treatment of glioblastoma? Well, the hypothesis is that glioblastoma, as it tries to divide, or really any malignant cell as it goes through division, has to do what normal cells do, which is line up its DNA, build a microtubule, a cytoskeletal structure, and more or less divide its DNA to one daughter cell and the other daughter cell, as well as divide up its organelle structure and other aspects of the cell. So what TTFs do, and the proposed mechanisms, is that it interferes with microtubule polymerization because these microtubule subunits are dipoles. They have a north end and a south end, and just like magnets, get sort of stuck together. So they have to align and polymerize to create these structures to pull the DNA from one end to another. When you introduce an electrical field, these little blue lines are an electrical field, it arrests these little microtubule subunits and their dipoles into just a singular direction. So they can't assemble the microtubule spindle complex and therefore cannot divide up the DNA appropriately. So that leads to apoptosis. And also there's this, as I mentioned, this abnormal segregation of chromosomes, but also an abnormal segregation of organelles. Preclinical data that suggested that this might be efficacious was, you can see here with electron micrographs, TTFs, when applied to these cell lines known as LN18 and ZH161, you can see that TTFs induce autophagosomes as well as mitochondrial disruption, as indicated by these arrows. The positive control here is staurosporin, so it kind of has a similar effect on these cells. It also is a very much a frequency-dependent manner, so these TTFs work at a certain frequency. Too low a frequency, clearly the cells will continue to grow. Too high a frequency, it won't affect the cells enough. So therefore, glioblastoma cells have actually been determined to work at a frequency, to be affected, at a frequency of 150 kilohertz. And this is just a graphical representation of actually multiple cell lines. These are lung, melanoma, and GBM cell lines. And you can actually see that there are some cell lines that do much better at a lower frequency, some cell lines that do much better at a higher frequency. This 200 is actually, I believe, a lung cancer cell line. There's actually a clinical trial here at UNC looking at that very question for lung cancer brain mets and using the Optune device to try to inhibit lung cancer brain mets. But glioblastoma falls somewhere around here at about 150. It also is very dependent on the intensity of the field. The greater intensity of tumor treating fields, you have a relative decrease in cell number as well. This is just another micrograph of controls versus TTFields cells. You can see this abnormal distribution of the DAPI staining genetic material within cells. You see how this is nice and equal here, and you have this very much unequal distribution of organelles and cells, and very, very asymmetric appearing cell structure here as well. So you can actually use a targeting system to map out your arrays on a patient's head, so you can become certified in it, and it's almost like a radiation oncologist mapping out and it's their treatment fields for their radiation. You can do the same thing using this Novital system. And this is really where the money is. This is the data, the 5-year survival analysis for the combination of TTFields plus chemotherapy versus chemotherapy alone. This is this study was started, I believe, in 2013, 2012, known as EF14. This is the progression-free survival analysis. You can see a very nice split and a difference of 11.2 months PFS versus 7.8 months PFS in the chemotherapy alone arm. And this is the OS at 5 years, and you see that the OS is basically 21 months versus 16 months in the chemotherapy alone arm. If you recall, the Stupp paper was 2.5 months, and we made a big deal about that. This is double that, which is very, very impressive. You have 43% of patients at 2 years that are still alive, which is a great number to go for when it comes to GBM, and versus 31% in the control arm. This is long-term survival rates at 1 year, 2, 3, 4, and 5 years. You see that in the TTF plus chemotherapy arm, you see that there is an increase. And what's most striking is that this 5% here is actually what's pretty much quoted across the board prior to TTFs. Rather prior to the advent of TTFs. We know that 5% are still alive at the end of 5 years. That number increased in this study from 5% to 13%, which is greater than double that survival, which is very impressive and much needed for this disease. This is a subgroup analysis of 5 years. You have your methylated patients benefiting from it, your unmethylated patients certainly benefiting from it, patients that got a gross total all the way up to a biopsy benefiting from it. You have your older population, greater than 65, which has been classically difficult to treat, also benefiting from it. Your performance status, less than 80 KPS, in this case about an ECOG 1 or nearing 2, also benefiting from it, and males and females also didn't have a difference in terms of benefit. This is survival by compliance. Now, we talked about the 18-hour per day compliance. It's very important that these patients try to maintain that, and that's about 75% of your day and averaged out over a month. It can be quite a bit. So you have about 25 days that you have to wear it out of a month with 3 days off. So you try to kind of spread that 3 days around, at least this is what I tell my patients. But it says in those patients that did comply with that 75% cutoff, they did have a survival advantage in those individuals that did not. However, even those individuals that were as low as 60% did have a benefit to wearing the device concurrent with their chemotherapy. And clearly the ones that did get the most benefit are those individuals that had a 90% or above compliance with the device. This is functional scale, so a lot of questions that I get are on quality of life and what do those metrics look like. These are fairly established quality of life metrics and questionnaires that we use all the time in oncology, and it looks like it's about the same throughout. Global health, functional status, cognitive functioning, social functioning, emotional functioning, things like that. It seemed to be about the same, if not even maybe a little bit better, in some of these groups. And in terms of deterioration-free survival, so again, we're looking at sort of the quality of life questions. They tended to favor tumor treating fields with the chemotherapy, except for the itchy skin, which is a common complaint that I get from my patients wearing the device, especially here in North Carolina, which can be very hot and humid. This is actually a patient of mine that agreed to be interviewed for a discussion that I was having with Lineberger in his publication about what it's like to wear the device. He was fairly compliant at 79%. I do get a report card on my patients about once a month about how they're doing, and it basically tells me the daytime hours and the evening hours of how long they're wearing it. You can see here that he did take breaks. He did take it off throughout the month to clean the scalp, shave the skin, look for any kind of dermatological issues, and would put it back on. And speaking of that, really the main side effect is skin toxicity, and in this case it's more so the dermatitis. But dermatitis can evolve, and it can evolve to erosions, folliculitis, pustules, and overt ulcerations. And these are some of the potential causes. So chemical irritation from the hydrogel, which is a very similar compound to the EKG hydrogel that patients use when they get their EKGs. The rubbing alcohol that occasionally can irritate the skin if it's used quite a bit to kind of clean up the scalp between the array changes. Tearing the arrays off too quickly can damage the skin just like a Band-Aid could. And honestly, just basically letting all of these issues kind of snowball into frank ulcerations and infections, and skin infections like cellulitis and folliculitis. All of this is actually very much preventable. It's all about making sure that you're washing the patient, make sure that family members are able to inspect the scalp before reapplying the arrays. So managing skin toxicity also very important. It can be as simple as lotions for some of the very mild skin redness and dermatitis, to using a medium potency steroid such as clobetasol, applied twice a day, once or twice a day really, to the scalp, to kind of manage the local inflammatory response. And for those areas that have infection, you will have to discontinue the arrays, let things kind of heal up, use perhaps a topical antibiotic, such as a triple antibiotic, or maybe even sometimes an oral antibiotic if you're dealing with things like folliculitis. Sorry about that. So clearly it's very patient dependent, but really just making sure that they have close monitoring and just careful observation, and giving them a little bit of time off the arrays can prevent a lot of these problems in the future. So what do we do at recurrence? So we've established that we can use TTFields for newly diagnosed disease based on the EF14 data, but what do we do at recurrence with this device? So just a little bit of background on recurrence. You see that as a function of performance status, those individuals that have a better performance status in ECOG of 0 or 1 do a lot better than those individuals with an ECOG of 2. This is kind of a no-brainer here. So you're looking at 10 versus 4 months in these patients at recurrence. Neurological deficits obviously play into it, so people without any neurological deficits do a lot better than those individuals that do have neurological deficits. Tumor location, a frontal lobe tumor typically does do better because it could be resected again, it could be irradiated potentially, and it may not cause the overwhelming mass effect as those tumors that are deeper within the brain and are closer to more eloquent structures such as speech centers and the brainstem. So at disease recurrence, it's truly a kind of a wild west when it comes to treatment. There are no standard treatments. We go between re-challenging with temozolomide, this metronomic schedule, using Avastin, and that's a discussion all its own in terms of its evolving role. Lomustine, which is an old, fairly toxic chemotherapy, irinotecan, carbo, etoposide, even gliadel wafers have been looked at in a recurrent setting. Optune, which we'll discuss in a little bit about its role, or a combination of any of these interventions, including the Optune device, but really what's preferred is a clinical trial. So the scenario we have here is a patient that starts TTFields with its maintenance temozolomide just per the EF14 trial, and then progresses. So what do we do then? Is there a benefit for continuing TTFields at first progression? Well, there might be a signal of benefit based on this study. This is actually a post hoc analysis that was recently published more or less as an abstract, and I'm hoping to see more mature data as we continue to analyze it. But basically, this is the post hoc analysis of EF14, and it's those individuals they looked at who progressed on TTFields plus chemo versus chemo alone, and what those patients got later on. So this wasn't part of the study necessarily. They were all part of the intention to treat analysis, but they took those patients and looked at how well did they do when they kept TTFields on and added a different chemotherapy or used a different modality versus those individuals that either went off the TTFields or just went on chemotherapy and stayed on chemotherapy. And you can see here that there were two groups. Again, this is all post hoc. This isn't the intent of the study, but it's interesting because, again, as I stated, it might give a signal in terms of which direction this is going. But pretty well balanced groups in terms of what they got after at first progression for their glioblastoma. You can see here pretty non-significant changes there. And they looked at sort of the Kaplan-Meiers and see how patients did over time, and you can see that more or less there was a trend towards a survival benefit for the patients that may have continued TTFields later on, combined with some sort of different cytotoxic chemotherapy. So it's a signal. I don't think it's certainly conclusive that we should be doing this, but it's something that we should be exploring, perhaps prospectively in the future. What about the patient that never got treated with TTFields and progresses after maintenance? Temozolomide is basically an EF14 data, just the chemotherapy arm. Well, based on the EF11 study that was published in 2013 or 2012, TTFields were looked at comparing physician's best choice chemotherapy, and you can see pretty much whether you look at chemotherapy or TTFields, it was pretty dismal survival overall. Potentially a signal here for TTField benefit, just like we saw here. But again, once the tumor really gets going, once sort of those molecular changes add up and it becomes a smarter tumor, you have less and less efficacious options, at least conventional options outside of a clinical trial, to fall back on. This is why we need better treatments. So with that being said, we have a few questions for you, and I'll read them out. So we have a 59-year-old male who presents with seizures. MRI reveals a right temporal lobe lesion. The patient undergoes a craniotomy, which reveals a glioblastoma in path. Which molecular marker or markers have been shown to predict for a favorable response to chemotherapy? So I'll give you guys some time.
Dr. Khagi, do you mind reading those out just in case anyone has particularly small text on their device?
Sorry about that. So A is IDH mutation, TERT promoter mutation, and MGMT promoter mutation. MGMT promoter mutation only, IDH mutation only, or MGMT promoter methylation status and IDH mutation.
All right, we definitely have a trend. How are they doing?
Not that great.
Oh.
That's okay. That's all right. With IDH being as important as it is, as I mentioned, it's more prognostic at this point. And certainly patients do better when they do have an IDH mutation, but they tend to do better regardless of treatment sometimes. So the answer that I was looking for is actually just the MGMT promoter methylation status truly is the most predictive of those biomarkers that we have right now. TERT I threw in there. There's a little bit more information that's coming online about TERT and its importance in survival. But again, it's not predictive. IDH mutation is not predictive. It's prognostic. So really the only biomarker here, as I said, is MGMT.
All right, thank you.
Yeah.
And thanks to our audience and these are anonymous, but thank you for taking a shot at that.
I think we're all very lucky that this is a pretty rare tumor,
yeah,
and that it's only 2% of your board. So
all right,
all right, all right. Yeah, like I said, B. Okay, so next question. Again, we have our 59-year-old male who presents with a new diagnosis of glioblastoma. So basically shows up to your clinic. The path shows an MGMT promoter that is methylated. IDH status is wild type, so we know this is a primary de novo glioblastoma. He has undergone a gross oral resection, and what that means is that he's gotten at least 90% of all enhancing disease has been removed. And his ECOG performance status after resection is 0. What is the next step in management? So A, radiotherapy, B, chemotherapy alone, C, concurrent chemo plus radiation and application of TTFields, or concurrent chemotherapy and radiation.
And while we're waiting, we do want to thank all of you for participating in these polls, and it's great to see the numbers moving back and forth and see so many people going ahead and trying to get that correct answer.
All right, so looks like more or less most of our audience has chimed in. So the correct answer is D, because we're looking for the next step in management, right? And that is the application of concurrent chemo and radiation. We do not use TTFields during that time. It is during the maintenance course of chemotherapy, after their concurrent chemotherapy and radiation course, that we use TTFields. All right, so we don't want to apply these arrays while a patient is getting radiation, at least not at this point. So, so the answer is D. But we do use it with maintenance, so I want to make sure that's clear. All right. Okay. So we have a 59-year-old male who presents with our glioblastoma, completed concurrent chemo RT, and you discussed TTFields and the data supporting its use. You also mentioned the toxicity related to TTFields. What do you quote as the median survival advantage in newly diagnosed GBM when comparing TTFields combined with chemotherapy versus chemotherapy alone? And what is the most common side effect or side effects associated with the device? Okay.
All right.
You guys did a lot better here. 85% said C, approximately 5 months, and the toxicity I was looking for was dermatitis, the most common one. So very good, very, very good. The other ones, those are basically made up. The approximate 2.5 months was actually more so the Stupp data from 2005. So I'm glad you guys had that 5-month survival advantage. Right on. Good job. So another question, again, the same patient with a GBM completes 12 cycles of maintenance chemotherapy and TTFields. So he presents for a 20-month follow-up with an MRI. That's very good by most standards for this disease. But unfortunately, his MRI reveals progression of disease localized to the right temporal lobe, so where his original tumor was. What is your preferred recommendation? So starting metronomic temozolomide and reinitiation of TTFields. Start bevacizumab. Start lomustine and bevacizumab, or a clinical trial. All right. Looks like most people already answered, and you guys did really well here. 71% said clinical trial. That is correct. There is no standard second line or third or fourth line therapy for glioblastoma. I know we think about Avastin or bevacizumab being sort of the go-to, but again, that whole paradigm is entirely being challenged because it's never been shown to have an overall survival advantage, just a very nice PFS because it makes MRIs look really nice. And the lomustine data did not show an advantage of combined lomustine plus bevacizumab versus bevacizumab alone, so the curves were exactly overlapping. So really, in our patients, we should be enrolling them in clinical trials, whether it's a viral therapy, CAR T cells, or just other novel approaches. Clinical trials are the way to go for our patients if they are available. So I think that's it. Thank you for your attention. I really appreciated the opportunity to chat with you guys. Thank you, Tim, for inviting me. So any other questions?
Let's see. I'll go ahead and snag this. So we should, oops, I hope I didn't jump over it. There we go. So this is where you can go ahead and, as an audience member, submit your questions to Dr. Khagi. Just go ahead, and if you haven't already joined the poll everywhere, you can just UNCCN to 22 with the number 22333. There we go. We've already got questions rolling in. When you spoke about the OS and treatment of recurrence, did the subjects truly have an ED period, or was it progression of disease?
So it's kind of hard to have no evidence of disease. When it comes to glioblastoma, there's usually some radial enhancement or some residual flare change. That is kind of hard to say whether it's disease or whether it's a radiation effect. Remember, these are MRIs. They're not microscopes. We can't really get a PET scan to say one way or the other. So at the time of progression in many of these patients, we do use criteria. One of these criteria is called RANO, radiographic assessment in neuro-oncology. We can also use physical criteria, but if the patient's KPS is dropping, they're more symptomatic, they're having more seizures, more headaches, and MRI suggest increase in enhancing disease, increase in flare, for example, new areas of disease, then those are all considered pretty much progression of disease. So that's how I would measure it. And then there's another question. Why do you think patients progress while on TT treatment? Do the tumors become resistant? How? That is an excellent question. The bottom line is that we don't really know why these diseases progress after TTFields. The idea is perhaps based on the fact that the frequency that we chose, or rather, that 150 kilohertz frequency is based on the actual size of the tumor. It has to have, like I said, a size, and the physics are not entirely well understood by me, at least. It's based on impedance and permeability of these different frequencies, but it is based on how big the cell is. And also the orientation of each individual cell. So if you have a cell that is either too small or too large, or oriented in such a way that the fields just can't penetrate it adequately, then you have potentially a resistant tumor. So at least that's the hypothesis. But yes, you're right. You would think that this might be a panacea, a cure for this disease, and really hasn't turned out to be. So it's a disease that we're still trying to figure out why it's resistant to it. Maybe perhaps adjusting the frequency could work. We have yet to have a device that's approved by the FDA to do that yet, and I think those studies are ongoing. Is there pediatric testing of TTFields? I believe that there is a study currently enrolling in pediatrics. So yes. Are most insurance companies on board with covering TTFields? If not, is the company still providing assistance? As far as I'm aware, those insurance companies that do not provide initial approval, the company will actually go through the very exhaustive appeals process to get the device. And if it exhausts all of its ability to get the device, then it does provide patients with some assistance. I believe that is still very much the case. Most insurers do seem to be getting on board, especially after that NCCN 1 Category 1 recommendation. Next question is, how many trials are currently open to accrual in your brain tumor program? Thank you for the plug. And who are the coordinators? So we have a oncolytic virus study using adenovirus combined with pembrolizumab for recurrent disease. So they have to meet certain inclusion-exclusion criteria, as all of them do, but basically first or second recurrence, can have been exposed to Avastin, so that's actually we're pretty good about that. But the tumor has to be pretty localized and not more than 4 centimeters in size, and you can't have any satellite lesions or crossing the midline. So that's our sort of singular trial right now for recurrent disease. We're currently working on opening up others. We have a new one opening up probably next month or two for newly diagnosed glioblastoma, where we're going to use a cocktail of plasmids that are going to be injected intradermally and then electroporated in order to allow those plasmids to come into APCs and dendritic cells, and then we're going to stimulate the immune system with another checkpoint inhibitor. So our clinical trial is evolving. Our clinical trial portfolio is currently evolving, but it's, glioblastoma is a big focus of ours. And who are the coordinators? Lisa Brett and Corey A. Moore are my 2 coordinators, but the best way to sometimes get in touch about our trials is to contact me directly, and I'm more than happy to share my email with all of you. When using TTFields, why are normal cells not affected? Well, normal cells in the brain are not typically dividing. So usually after age 22, your brain stops dividing. So that's why it's important to really maintain a healthy brain, because what you've got after age 22 is what you've got. But at the same time, TTFields will not affect normal, healthy brain cells.
And let me chime in there, because I did have a question related to that. What about dermal cells? Is the skin impact?
Right. So because of the frequency that is used, that frequency is calibrated to affect only dividing cancer cells, in this case GBM. So skin cells, that's a great question. Skin cells are not affected by it because they don't fall within that size parameter.
Perfect. Thank you.
Are there any clinical trials for metastatic lung cancer to the brain with Optune? Yes, we do have a clinical trial currently looking at non-small cell, first occurrence of non-small cell brain mets, combining the Optune device with SRS, so standard of care, versus SRS alone. So, yes, so we do have that trial currently available for our lung cancer patients. I may have missed this due to technical problems. What are the radiation recommendations? Well, for glioblastoma, it depends on performance status and fitness and age, but typically it's 60 gray with concurrent temozolomide. That's about 6 weeks of radiation Monday through Friday. For the elderly population, or those individuals with a poor KPS or ECOG, it's 40 gray. Monday through Friday, so that's about 3 weeks of radiation. And just a point that I want to make is that perhaps I didn't make it very well during the presentation. We do not use TTFields during radiation with chemotherapy and radiation. It's after. It's during the maintenance phase of treatment after they finish their 6 weeks of chemotherapy and radiation.
I'll just follow up with that individual. Please make sure to let us know in your evaluation what technical issues you were having, and then we'll also have the clean recording of this presentation available in a few days.
All right, next question. Is there any data to support Optune as an adjuvant therapy after chemoradiation? Yes, so that's the EF14 trial where we combined temozolomide plus the Optune device. So yes, so that's excellent data, 5-month survival advantage. So I think it certainly has a role as adjuvant, as adjuvant therapy after chemotherapy radiation for GBM. And last question refers to patients who complete maintenance. I
think that's a follow-up to that previous question.
Okay. All right. Well, thank you very much for joining us today.
All right, a few things to go over. Let me just wrap up by saying thank you to the generous support from the North Carolina Legislature for the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, and John Powell for all the work that they do to make each and every one of these presentations possible. Upcoming, our next RN and Allied Health lecture is on October 10th. At noon, that's Understanding Oncology Drug Interactions with Dr. Morgan. We hope you'll be able to join us for that. And then on October 24th, our next Med Surg lecture, and that's aerobic and resistance exercise in cancer patients. Methods and Benefits, and that's with Dr. Bottiglini and Dr. Wood. Those both promise to be great lectures, so we hope that you'll be able to be here for those. We do have more self-paced courses available. Now we've got the palliative care options with Nicole Sartor available on our portal, as well as recent advances on the gut microbiome and cancer therapy with Dr. Keku. So we hope that if you were not able to attend those, you'll go and sign on, and you can watch those and then receive credit for those. So let us know if you have any questions about that. Thank you for being here. We love our audience. We're very appreciative to each of you for being here today. Questions, you know where to find us, 919-445-1000. You can email us, unccn@unc.edu, and find us on the web at unccn.org. In closing, I want to say thank you to the over 100 individuals who responded to our survey to help us plan for 2019. We had outstanding responses from so many of you, and we really appreciate your taking the time to do that. Until next time, thank you for being here. Dr. Khagi, thank you so much for this presentation. Really appreciate it.
Thank you.